Good afternoon, everyone. I am Dr. Manjula on behalf of IAP Bangalore, Fever Foundation, and Micro Knowledge Academy. It gives immense pleasure to welcome the President of IAP Bangalore, Dr. Ravishankar M, and Secretary IAP Bangalore, Dr. Sumita Nayak, and renowned pediatrician and moderators of the program of today, Dr. S. Balasubramaniam and Dr. Jagdish Chinnappa, and our eminent speaker for today, Dr. Ramasubramaniam, and warm welcome to all the attendees of this program. Before we actually start the webinar, I just very quickly brief you all about Fever Foundation. Fever Foundation is a independent, non-commercial foundation supporting the educational and the academic activity to address the unmet needs in fever management. The foundation is committed to conceive, build, and sustain programs and make scientific initiative aimed at providing evidence-based update to healthcare professionals. Fever Foundation runs patient education programs on fever management. It engages the eminent doctors for various scientific activities. Microlabs is an unbiased scientific partner in the activities of Fever Foundation. Coming on to very quickly on the activities of Fever Foundation. Fever Foundation conducts annual fever conferences, Fever CME. It brings out book on fever management, it does clinical and epidemiological research, and other activities include challenging case presentation competition for postgraduates of medicine as well as pediatric, Young Scholar Award, patient education, paramedical education, and public awareness and programs. So till now we have done two annual conference. We call this conference as FEFCON, Fever Foundation Conference. The first was in 2018, where we had more than 300 delegates. So the uniqueness of this program is that pediatricians, physicians, infectious disease specialists, all the clinicians and the paramedicals who are involved in the fever management come under one roof to discuss about the issues, challenges in the fever management. And we had the second conference in 2019. We had more than 400 delegates. So these conferences are accredited by Credit Point by Karnataka Medical Council. So the third conference we are planning in the month of November. As you all know, we are in the difficult times, COVID times. So we will review if possible, we will be having the physical conference or it will be a virtual conference. So we have brought about 4 books till now. First, after every conference, we bring about 2 books, one for pediatrician, one for adults. And first year 2 books, and this 2019 also. If any one of you are interested in needing this book, you can just contact the Microlabs manager or representative. They will share the books with you. And Fever Foundation also conducts CME programs across India for postgraduate students, both physicians and pediatricians, as well as general practitioners. The modules are prepared by our eminent advisory board members, and we have national faculty panel, which is created apart from the advisory board to conduct the CME across. So our plan is to conduct one CME in each zone every month, north, east, west, and south. So we had started this program in August 2019. Till now, till February, we have conducted more than 25 CME. Since March onwards, since the lockdown and everything came in, so we were not able to do the physical CMEs. Now we are conducting the webinars or virtual CMEs. And Fever Foundation is into clinical epidemiological study of rare topical fevers. We have identified, our eminent panel have identified 2, scrub typhus and brucellosis. Currently, the National Multicentric Survey is ongoing. If any one of you want to be part of this, please get in touch with us on these 2 diseases. So that's quickly about the Fever Foundation. So now to get on with this today's webinar, which is COVID-19, Insight into Clinical Features and the Rational Management in Indian Scenario. So to conduct on this program, we have eminent moderators today. Both of them do not require introduction. They're well known among all the pediatricians across India, but since we are having other specialty also, I just very briefly introduce them. It's my privilege to introduce Dr. S. Balasubramaniam, is MD, FIAP and FRCPH UK. He is currently the Medical Director, Head of Department of Pediatrics and Senior Consultant at Sri Kanchi Kamakoti Child Trust Hospital. His very briefly his achievements, he is the course director for IAP Fellowship in Pediatric Infectious Disease. He is examiner for RCPCH for the last 5 years and MRCPH and DCH for the last 2 years. He has published more than 75 articles in Index Medical Journal. He has contributed several chapters in many popular books. He is on the advisory board of ICMR Respiratory Disease. He is the principal investigator in several national and the international vaccine trial. He's been the president and vice president of IAP Tamil Nadu. And several awards, to name a few: Best Teacher Award by Sri Ramachandra University, Lifetime Achievement Award by Dr. MGR University, several oration awards, Tamil Nadu State, Karnataka State, Coimbatore, etc. And he has been awarded the Distinguished DNB Teacher and Excellent Award for National Board of Examination. Sir, it's a very pleasure to have you. The most welcome to this program, sir. The second eminent moderator is another eminent pediatrician, Dr. Jagdish Chinnappa. He is a consultant and cluster head at Manipal Hospital, Bangalore. He has been various committee of Indian Academy of Pediatric, to name a few: National Respiratory Chapter, Immunization Subcommittee. He's been involved in the curriculum development for the pediatric guidelines on asthma, respiratory infection in children. His expertise in emergency care, nutrition, developmental assessment, and respiratory care as well. And he's a national convener for HOPE program of IAP. He's been actively involved in our Fever Foundation for all our educational activities, CME programs, in developing the modules as well. Is involved in the several research activity, both at national level and the international level, and educational programs as well. He's an eminent speaker in both the national and the international freedom. So all of us who have worked with him closely known for his, we know about his organizational skills and the lateral thinking. So, sir, it's our pleasure to have you in this program, sir. Again, warm welcome to you, sir. So may I now request the moderators of the program to start the proceeding and take the program forward. Thank you very much.
Thank you, Dr. Manjula, for that wonderful introduction of Dr. Balasubramaniam and me. And what we'll have for the flow is that we will have Dr. Balasubramaniam to introduce Dr. Ramasubramaniam, and then we will have Dr. Ramasubramaniam's lecture, which we are all very eagerly looking forward to. And then we will take question and answers from the panel. And if any clarifications are there, both of us will moderate that. And then finally, we'll have Dr. Sumita and Dr. Ravi Shankar to give us the final word on the program. So I invite Dr. Balasubramaniam to start with his deliberations.
Have I stopped sharing, Dr. Krishna, or still it is there?
No. Sir, it's over to Balasubramaniam, sir.
Yeah. No, my content sharing is stopped, right?
Stop.
Okay, thank you. Sir, you are muted, sir. Kindly unmute. Yeah.
Am I audible?
Yes, sir. You are not.
Yeah. Thank you, Dr. Manjula and Dr. Jagdish. And I thank the Bangalore Pediatric Society for giving me the honor of moderating this unique session. And I thank Dr. Jagdish Chinnappa for this opportunity. I have great pleasure in doing the job of introducing a very important personality today in the midst of COVID pandemic, Dr. Ramasubramanian. Dr. Ramasubramanian is the consultant in infectious diseases and tropical medicine of the Apollo Hospitals, Chennai. And he is also the adjunct professor of infectious diseases at Sri Ramachandra Medical College. And he is also an adjunct professor of infectious diseases at the Tamil Nadu Dr. MGR Medical University, Savitha Medical College. And he is also the adjunct professor of infectious diseases at the Apollo Hospitals Educational Research Foundation. He is also the director of Capstone Clinic. In fact, when me and Jagdish decided to have this topic, a very peculiar one, with the aim of sensitizing all doctors in India, irrespective of their specialties, to the principles of management of COVID-19 today in the midst of the pandemic, we had no better choice than Dr. Ramasubramanian. Why so? Dr. Ramasubramanian, after his MBBS degree in Madras Medical College and then the MD in Chandigarh, he went to UK, got his MRCP, got his diploma in tropical medicine, got himself trained in infectious diseases, came back to give his knowledge and his expertise to this country, and he has settled down in the metro of Chennai in a unique way that whenever we think of difficult infectious diseases problems, irrespective of the age, we always look to Dr. Ramasubramanian, and we actually trouble him with a lot of phone calls and emails for consults, official and unofficial, personal and social. Dr. Ramasubramanian's unique characteristics are: one, very sharp clinical acumen; two, a no-nonsense approach; three, he is very much updated with the latest guidelines in infectious diseases; four, he has put Chennai in the roadmap of infectious diseases in India. He and his team have established a fantastic infectious diseases team at the Apollo Hospital. In addition, when people do so well in academics, they don't do well in practice. But Ramasubramanian is an exception. He has started a unique clinic called Capstone Clinic, where he has a multi-specialty clinic. And unlike pediatricians, adult physicians usually don't bother much about immunization. And Dr. Ramasubramanian has the unique distinction of starting a clinic called Immune Boosters, giving immunization advice and immunizations to adults. A very, very, very novel idea, and he has been successful in this. So these are the reasons why me and Dr. Jagdish zoomed on Dr. Ramasubramanian for today's discussion on management of COVID-19, but with particular focus on adults, more so because all of us have some friend or relative in some ICU or at home quarantine with COVID-19. With this introduction, I would request Dr. Ramasubramanian to start his presentation on COVID-19. Thank you very much.
Good afternoon, everybody. Thank you, Dr. SBS. It's a pleasure to be with all of you this afternoon and talk to you about COVID, and thank you for the very nice words you have said about me. I would like to make a disclosure here that today's talk, as suggested by Dr. SBS, I'm going to strictly confine myself to only the specific management aspects of COVID, and I shall not venture, at least in my presentation, to talk about other things, including infection control. And two, I have probably added a heavy dose of common sense to my approach and talk today. So the idea is not to do fancy things, because the primary principle of medicine is at least do no harm. So when we are faced with the uncertainty of managing COVID, I think what we need to do is ensure that we do only the basic minimum or the necessary things to keep our patient, healthy and come out of COVID, and avoid doing adventurous things based on, anything which we read on the social media or anything which has just come out in the newspapers a couple of days before. So with these words, I'm going to share my Are you able to see my screen now?
Yes, sir.
Right. Okay. So this is a very favorite poster of mine, and it is a cartoon which is very useful during these times. The papers are coming out at a rapid succession in the last few months, and most of the papers are free to access by all of us. When you read the abstract, they look very robust. Then you read the introduction, it does not appear as robust as it started. And then when you get to the results, unfortunately, it is a lot of flab and not much muscle in it, which is what we are seeing in most of the publications which we are coming across these days. So please remember that there will be a lot of changes coming up. There will be a lot of evolution happening with our knowledge towards managing COVID. But I think we need time to build muscles. We need time to ensure that what we do is correct and not something which is just fancy and adventurous. I'm going to start with the first couple of slides to tell about how this virus behaves, or what I would call as the viral dynamics. Now, the virus multiplies in an exponential fashion, which means it multiplies at such rapidity that the cases increase at a logarithmic level. If you look at the curve here, you'll find this is what we refer to as the exponential curve, where the virus multiplies steadily. And to give you an analogy, let us take a pond which has one water lily in it. Now, assuming that each day the lily multiplies by 2, on day 1 there is 1 lily, on day 2 there is 2, day 3 there is 4, day 4 there is 8, so it keeps going like that. And assuming that it takes about 30 days for the entire pond to be filled with water lilies, we need to understand that on day 29, only half the pond is full, on day 28, quarter of the pond, and day 27, 1/8 of the pond. So in a matter of the last 4 days, from 27, 28, 29, and 30th day, from the lilies being 1/8 of the pond full, suddenly the entire pond is covered with lilies. That is exactly the way in which the virus multiplies and transmits between people. And it is very scary that if you're going to wait till the numbers become impressive, it is already too late, which is what has happened in Tamil Nadu, which is what has happened in Chennai, which is what is happening in Madurai and probably Trichy. And let me assure you that it will happen in Bangalore. I know this is predominantly Bangalore-based session. You are just a few weeks away from or behind Chennai. When the virus hits you, it doesn't give you time because it is multiplying exponentially. And if we need to make a difference 2 weeks down the road, you need to make the intervention today. The reason why we flatten this curve and push this curve from here to here is so that this will give us time to handle. The healthcare system is given time to handle, expect the number of cases by ramping up infrastructure, by ramping up the ventilator facilities, by ramping up our treatment modalities and our intervention towards COVID. And even though the number of cases, which means the area under the red curve and the blue curve, are probably the same, by flattening the curve, it gives us time for the healthcare system capacity to cope with this onslaught. So please remember, you are going to face an onslaught very soon. I think there is no escaping that, and we should be better prepared. And what is a simple way to start? I very strongly believe in the culture of masks. This is a very nice picture which looks at the importance of masks in these countries where masks are not a culture, compared to, say, Hong Kong, Singapore, Japan, and South Korea, where the culture of masks has significantly blunted the incidence of cases. And I think unless we all take up masking, and if there is one message I want you all to leave with today at the end of this lecture, is that you need to wear masks universally. You'll find that if person who is symptomatic is not having a mask and people around him have a mask, the transmission probably is still as high as 70%. If the person who's having symptoms wears a mask, and even if others don't wear a mask, this transmission can be reduced to as low as 5%. And when the carrier and the contact wear a mask, the transmission is probably 1.5% or less. So the lesson learned, universal masking is mandatory if we are going to flatten this curve and make the curve turn low so that we can beat this pandemic at least in the next few weeks, if not months. So this is the main message I wanted to give you today before I move on to the concept of handling COVID. And this is again a reminder to my Karnataka friends. This is exactly how it happened in Chennai. You are looking at the lion, which you think is behind near the hill, but the lion is standing very next to you. And Tamil Nadu has got the lion ramping in the midst of the city, and you are going to have the same thing happening in Bangalore and other places. So I think we need to prepare ourselves. There is no escaping the fact. There is a lot of comparison between the COVID and the flu. There were a lot of social media posts which said that COVID is just like the flu, a little bit of mortality. So why are people so worried about COVID? It is something which the media is making a huge hype of. So if you need to compare the flu with the COVID, we usually use the term R0 or R0 to estimate the number of people who will be infected by one individual who is afflicted by the infection. If you look at the flu, the R naught is 1.3, which means every infected person can infect another 1.3 people. Whereas if you look at the COVID, it is more than double that. It is almost 2 to 3 times the number of people who can be infecting others when compared to the flu. So which means this is far more infectious when compared to the flu. The next is the incubation period. The incubation period of flu is much shorter, just about 3 to 4 days, whereas the incubation period of COVID can be anywhere between 1 to 14 days with a median of 4 to 5 days. If you look at the hospitalization rate, only about 2% of the people with flu get hospitalized, whereas almost 20% of people with COVID get hospitalized. And lastly, the case fatality rate of flu, it is about 0.5 to less, 0.05 to 0.1, whereas with COVID, even assuming that the experts say is correct and it is probably 1% or even less, still it is almost 10 times as infectious as the flu. So you put all these things together, you have a longer incubation period. The person starts becoming infectious even 2 days before the onset of symptoms. It is requiring more number of people require hospitalization, and the mortality is almost 10 times as much as flu. Putting all these things together, this is a huge problem. Even if the mortality is less than 1%, we are going to face a phenomenal number of patients requiring hospitalization, and a significant number of people are also going to die. So I may sound a little ominous, but please believe me if I tell you that the darkest days are still ahead of us. We have not come to full terms with this. We are going to face a problem, and even if we get over one problem, we may have a second wave and a third wave, and we have to prepare ourselves for this. I'm sorry I'm giving very dire threats, but this is something we need to accept. What are the symptoms of this COVID-19? The symptoms are very non-specific, though classically the symptoms were described as fever, cough, progressive breathlessness requiring hospitalization. We have realized in the last 2 months in Chennai that the symptoms by which the patients present is a phenomenal myriad of symptoms. It may be with cough, it may be with shortness of breath, fever, chills, severe muscle pains, headache, sore throat, diarrhea, loss of appetite, and most importantly, something which is quite typical of this condition is loss of taste or smell. Even though several viral conditions can cause loss of smell and taste, this somehow has a unique predilection in up to 1/3 of cases to cause a loss of smell and loss of taste. And the person may not present with all these symptoms. It could just be severe body aches for a couple of days. It could be just severe headache with sweating. It could be only a low-grade evening fever. It could be any of the symptoms in permutation combination. So if the most important advice, again, I would say after masking is, if any one of you develop any symptoms, as I said, repeat, it could be body pains, which is lasting more than a day or two. It could be severe chills or shaking. It could be loss of smell or taste. It could be high fever. It could be a persistent low grade without fever, without localization. If you develop any one of these, the most important thing you can do is isolate yourself. Do not wait to confirm the condition. If these symptoms happen, isolate yourself at home in a separate room. Wait for 24 to 48 hours. If the symptoms persist, then you have yourself checked out to see whether there is a possibility of COVID. This is the best way to make sure that you don't pass the infection to other members of your family or friends. And this is something which you need to always remember. What are the symptoms? As I told you, even though fever is mentioned as 80 to 90% of cases, in the large study of over 3,000 people done in China, they found at the time of admission only 40% had fever. And even after 1 week of hospital stay, only about 85% had fever. So fever need not be always present in patients with COVID. Cough is present in about 60 to 80%. Progressive breathlessness, usually starting after about 5 to 7 days, is seen about less than 50% of patients. Severe fatigue, body aches, joint pain, sore throat, headache, chills, runny nose, nausea, vomiting, diarrhea can all be symptoms. Either alone or in combination, you can get them. We also see patients with COVID presenting without any symptoms with just a myocardial infarction. with just a CVA, a stroke without any other symptoms. And if you probe, you'll say they had been feeling a little unwell for a previous couple of days. But you need to watch out for warning signs, which mean these symptoms lasting for more than 4 to 5 days, breathlessness, and they have what is called as silent hypoxia or happy hypoxia. A lot of people do not complain of breathlessness, but if you check their respiratory rate, they'll be doing about 24 to 28 at rest. So this is a very subtle sign which you need to check. Anybody who presents to you, always do 2 things. 1, check their respiratory rate. A person who is sitting comfortably at rest should not be breathing more than 15 to 18 breaths per minute. And 2, check the oxygen saturation. You'll be surprised that some of them may have saturations even around 90% without realizing that they are breathless. They are tachycardic, and towards the end, when they develop features of sepsis, they may have hypotension also. I already mentioned about the case fatality rate. The case fatality rate is actually less than 1%, but there are several factors which are associated with an increased mortality. Typically, it is age. You'll find that people over the age of 80 have almost a 15%, 1 in 6 chance of dying. People over the age of 60, again, about 4% case fatality rate. And anybody with underlying hypertension, diabetes, cardiovascular disease, respiratory disease, or cancers have an increased propensity to run into complications and die. All of us have the equal susceptibility to develop the infection, but case fatality can increase with underlying comorbidities and age. This is something which is very important, which means the vulnerable group, that is people who are elderly and people with comorbidities, should be extra carefully watched to see whether they develop any complications. When these people present with fever, the laboratory findings can be entirely non-specific. They may have a normal count. Sometimes the counts may be higher. It is believed that higher counts may portend a slightly poor prognosis. We don't know yet. Lymphopenia is marked. They may have a raised creatinine. Liver enzymes may be slightly elevated 2 to 3 times the upper limit of normal. The CRP is surprisingly quite elevated, especially in the elderly and people who may not do well. The CRP can be over 100 or even 200. LDH and ferritin is elevated, and similarly D-dimer also goes up, especially when the risk of complications is likely to be higher. The X-ray, even in asymptomatic people, may show changes. They may have patchy infiltrates, typically peripherally in the lung, and anybody with a fever more than 5 to 6 days, I would strongly advise to get a chest X-ray done, even if they do not have respiratory symptoms. The complications, as I told, would be patchy pneumonia. The CT scan, again, in asymptomatic people, can also show a number of changes, including patchy ground glass opacities, typically peripherally. It has been seen that the procalcitonin is in adults normal. It is not raised, but surprisingly in children, the procalcitonin may be raised. And similarly, if you look at the radiological investigations, in adults, they typically have patchy ground glass opacities, which may progress onto a crazy pavement appearance on the CT scan. In children, they typically have a halo sign, and they may have a nodule with a halo also. You may also develop myocarditis, features of myocardial infarction, shock, and sometimes acute kidney injury. All of this may result from a cytokine storm, about which I shall tell you in a few minutes. It is important that we categorize the illness as mild, moderate, and severe. Please remember that over 80% of cases are mild or slightly moderate and without requiring any hospitalization at all, which means the majority of the people do very, very well. You don't need to worry. It is only 20% who may end up requiring hospitalization, and 5% may end up in the ICU, and sometimes mechanical ventilator may be indicated. I'm talking about adults. Surprisingly, young children and pregnant women who do not do very well with flu do quite well with COVID. Children, most of them may have a couple of days of fever, upper respiratory symptoms, and recover. In fact, the inflammatory response, like a Kawasaki-like illness, is quite often seen in children. But apart from this, most children do very well. Mild patients are those with some upper respiratory symptoms with sore throat and may have diarrhea. They have a fever for a few days and then settle. They don't require anything other than home isolation. Cases who are moderate may have a tachypnea, may show a saturation less than 94% and tachycardia, and sometimes they may progress on to develop hypotension. These people need to be watched. So if you monitor the respiratory rate and ensure that the oxygen saturation remains above 94%, you don't need to put them into hospital. Severe cases are those where the saturation in room air is less than 90%, and these are the people who may develop progressive hypoxia requiring increasing or escalating oxygen supply in the hospital. So you need to be aware that every patient, especially as they grow older or those who have comorbidities who can be managed at home, need to be monitored with specifically respect to the oxygen saturation to see whether they warrant hospitalization. The next question, which a lot of us need to know, is when do you treat? When do you treat a patient with COVID-19? And surprisingly, in spite of the disease being around for the last 6 months, most of the associations, most of the agencies, most of the guidelines all say that treatment is purely supportive, which means the only two things which work are paracetamol and oxygen. Apart from this, all the other agents which we have been using is still only in the context of a study or a trial. None of them have been equivocally recommended as something which will improve mortality. And that is still true with all the agents which we have been using. Though we have been using a lot of them in the last few weeks, none of them have been unequivocally recommended as a choice of treatment to be used for patients with COVID. There have been several agents which have been tried. I'm afraid there's a little complicated cartoon. You will find that the SARS-CoV attaches to the ACE2 receptor and then enters. So the Chinese, when they started, used Arbidol. They have used Camostat mesylate, all of which prevent viral entry and fusion with the receptor. Chloroquine and hydroxychloroquine, which were very strongly considered as agents which would help patients, which have now entirely been given up, also seem to inhibit the viral entry and endocytosis by multiple mechanisms. Subsequently, once it attaches and enters, we need to block the proteolysis by using antiviral drugs like lopinavir, ritonavir, or darunavir, ritonavir. Again, these agents have been now almost but given up. Then we have other agents like ribavirin and favipiravir, which don't have much use at all. The only agent which probably has some effect is remdesivir, and I shall tell you about that subsequently. And we are also looking at other agents in the subsequent progress of the virus. But unfortunately, none of these have shown much benefit. We have also been looking at immunomodulatory agents. There is a cytokine storm. I'll explain how that happens. And by using these anti-interleukin agents or interleukin receptor antagonists, we believe that some of the complications of the cytokine storm can be blocked and patients can be saved. I will run through all the drugs which we have used briefly. We started off with chloroquine. I told you chloroquine is an anti-malarial agent, but it has several mechanisms by which it blocks the viral entry and endocytosis. There were a lot of mechanisms of action which were purported, and there were several Chinese trials initially. Then studies were done in both France and USA. And at the end of it, they concluded that this chloroquine is definitely not useful. And we can probably look at hydroxychloroquine, which has less side effects and better tolerated. So people started looking at hydroxychloroquine as a surrogate for chloroquine. And this was believed to be less toxic than chloroquine and has a longer safety record. And this was also done in several studies. But the result at the end of it is, including the WHO, I think except the ICMR, including the WHO, everybody has said that hydroxychloroquine has no role in the treatment of COVID-19. So at this stage, in the end of June, there is no role for using hydroxychloroquine in the treatment of patients with COVID-19. I'm very categorical about this. Then what about the role of hydroxychloroquine in prophylaxis? Except the ICMR, no other agency recommends treatment or prophylaxis for COVID-19 with hydroxychloroquine. Even the ICMR has a lot of reservations. There is a lot of, commentaries going on for and against. Let me reiterate that even though ICMR has said there is a role for prophylaxis, it is only in two groups. One, if you are a family or a household contact of a COVID positive patient, or if you are a healthcare worker who is dealing with COVID patients. It is only in these two populations there may be a role based on ICMR recommendations for using hydroxychloroquine. Please do not recommend hydroxychloroquine for any other groups of people just because they want to protect themselves. I've had a lot of queries regarding people asking me, I have elderly parents at home, should I give it to my elderly parents? Please don't. Even though the prophylactic dose is much lower on a weekly basis, it is still not recommended other than these two groups which I mentioned by the ICMR. So even HCQS is now completely out of the therapeutic arsenal in the management of COVID-19. The other agent which came to fore is the anti-HIV drugs, lopinavir and ritonavir, because it acts on the protease enzyme. There was no in vitro study, but it had been studied for both SARS-CoV-1 and MERS-CoV, which are very similar. The SARS-CoV-1 has a 70% homology to the current SARS-CoV-2. There have been studies, but unfortunately, again, none of them stood the test of scrutiny, and we don't currently the lopinavir ritonavir, except one study which used a triple combination using interferon, also showed some benefit, but most people also now believe that there is no role for all HIV drugs, whether it is lopinavir ritonavir or darunavir ritonavir. There is no role in the management, and we have stopped using it for the last over a month or month and a half. What about remdesivir? Now, remdesivir is the only antiviral which has been showing probably some benefit. It acts on the RNA-dependent RNA polymerase of the SARS coronavirus 2. It has been studied for SARS coronavirus 1 and also MERS-CoV to some extent. It is still an investigational molecule which was earlier used in the Chinese and the American patients on a compassionate basis. Then Gilead, which is a manufacturer, started insisting that you should do it only in the context of a trial. Subsequently, the FDA said approved it for emergency authorization use. And currently, there are several Indian companies, including Hetero Drugs and Cipla, which have come out with this. There are a lot of restrictions laid down on the use of these drugs. It is available. It costs roughly about 8,000 or 9,000 rupees for 100 milligrams. The dose is 200 milligrams on day 1 and then 100 milligrams for the next 4 days. Usually we use it only for 5 days. I will tell you what the indications are. The ACTT trial, which was the landmark trial which has been done so far on remdesivir, showed that there was some shorter time to recovery. So compared to people who were not given remdesivir, who took 15 days to recover, people with remdesivir treatment improved in 11 days. There was also a trend towards reduced mortality, though there was no definite statistically significant difference. There was no difference in the outcomes for patients who are on mechanical ventilation or on ECMO, which means the drug has to be used on patients who are admitted to hospital who are requiring oxygen. It is not recommended for those who do not need oxygen. The chances that it will help is very less if the person is already on mechanical ventilation. There have been studies which looked comparing between 5 and 10 days of remdesivir, and said that 5 days is as good as 10 days. So now we tend to use only preferably 5 days. In whom do we use? Since it is an antiviral, it should be used early in the course of the disease within 10 days of onset of symptoms. And as I mentioned, for people requiring supplemental oxygen, but not on mechanical ventilation or on the ECMO, duration is 5 days. It has side effects including GI disturbance, anorexia, nausea, vomiting, constipation, anemia, hypokalemia, hypoalbuminemia, thrombocytopenia, and also infusion-related reactions. You need to monitor the SGOT-PT and the creatinine on a daily basis and need to discontinue the drug because it can cause hepatitis. So if the ALT goes above 5 times the upper limit of normal, you need to discontinue. Or if there is worsening liver functions or INR, we need to stop it. With patients with impaired renal function also, you need to be careful, and it is preferably avoided in patients who have renal insufficiency. So remdesivir we have started using in Chennai. it is too soon for us to say whether it makes a difference, though some people in the Tamil Nadu government side swear by it. Our knowledge is still too limited. We have been using it only for the last about a week or 10 days or even less, and we have to see whether it helps. What about but amongst the ones I've mentioned so far, remdesivir is the only one which is indicated. What about favipiravir? Favipiravir is another antiviral which was introduced in Japan mainly, and Russia and China also have used it. It was used initially in the treatment of flu. It inhibits the RNA polymerase, and the initial studies were not very reassuring. There have been several studies done, but unfortunately, even in India, the studies have only looked at comparing favipiravir with other drugs. There is no study where you have said that favipiravir has been compared with a placebo to say it makes a difference. It is recommended for mild to moderate infections. As you know, mild infections probably do not require any treatment. They settle without any treatment. But this drug has been at least recommended as something for mild to moderate infection, but the evidence is very, 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 very sketchy. So if you ask me, would I recommend favipiravir for my patients? I doubt it. I don't think we have enough evidence as of now to recommend favipiravir routinely. It's come up with a lot of pomp and show at a time when we are scraping the barrel for something to use, so people want to use this, but scientifically, I think there is very little so far in favor of using favipiravir. What about other antivirals? Oseltamivir has no role. Another drug called Arbidol or Umifenovir, which is a Russian molecule, which has been used also in China in the treatment of flu. Initially, it was used in China, but has shown no benefit. Ribavirin, an hepatitis C and B virus drug, was also studied mainly for SARS and MERS. And again, though there has been one study where it has been used in combination with two other drugs, so far there is no recommendation in using either oseltamivir, umifenovir, or ribavirin in treatment of our patients. What about interferons? Interferons also has been studied because it's an antiviral agent, and the Chinese guidelines also recommended the use of interferon, but there is so far no definite evidence to say that it works. So amongst all the agents I've mentioned so far, the only agent which shows some amount of use is remdesivir. What is more clear is what are the agents we need to avoid using. The agents which we need to avoid are ACE inhibitors and angiotensin receptor blockers. Why is that? It is believed that these ACE inhibitors, which block ACE receptor 1, can cause an upregulation of receptor 2 to which the virus attaches. So theoretically, there is a concern that by using these, you may increase the receptors available for the virus to attach to and may cause a problem. But so far, there is no definite evidence. This is theoretical, and it has been made very clear by the cardiological societies, the hypertension societies, and the diabetic societies that if somebody is on ACE inhibitors and doing well, giving the medicines, you don't need to stop it, worrying that it may cause a problem. Azithromycin with or without hydroxychloroquine is no longer recommended. It increases QT prolongation and causes side effects. HCQS, as I said, is to be given up. Lopinavir, ritonavir, darunavir, ritonavir, no role. Famotidine, no role. Please don't use NSAIDs. There have been studies where, or rather hypothesis saying that indomethacin may work. No, it is not recommended. NSAIDs also have a role to play with the ACE receptors, and it is not something I would use. Only paracetamol should be used even for control of fever. Ivermectin, nitazoxanide, again, absolutely no in vivo study to say that it helps. It should not be used. I know a lot of people use a combination of ivermectin plus doxycycline based on studies available, not studies, anecdotal use from Bangladesh, absolutely no use. So I don't think we should. This is like trying to do something with the hope that it will work without realizing that it may do harm. So I'm very clear about this. Lastly, people are taking industrial doses of vitamin C and zinc with the belief that it will improve immunity against COVID. Let me tell you, even improving immunity as such against viral infections is at best tenuous with the use of vitamin C and zinc. And there is definitely no role specifically to say that the immunity against COVID is improved by taking these drugs. I think it is perfectly acceptable to take vitamin C or zinc. That is good, but not, as I said, high doses or not with the intention that it will protect you against COVID. We don't have evidence to say that it protects, but it can be part of a multivitamin tablet, which all of us may take. If it makes you feel good, I think that is acceptable. And lastly, I don't think there is any role for disinfectants. I think we all know about Trump's allegations and the lack of evidence. Now, if you look at the immune response of COVID, we realize that it is not a virus which directly acts against the body and causes harm. It's not like typhoid, causing inflammation of Peyer's patches. It is not like tuberculosis, which affects the lung and causes damage to the lungs. The immune response is actually of two types. The one is called the lymphoid response. Lymphoid response happens when the virus infects the cell, interferons are released, and these stimulate the lymphoid cells to produce antibodies. Now, the lymphoid response resulting in antibody production against COVID-19 is a very, very small aspect of the immune response. Somehow, the antibody production in COVID is very, very blunted. That is why even people who recover show very low levels of antibodies, which may not be protective also. So that is another whole, PhD thesis to go by. What actually happens is a predominant myeloid response. And what do you mean by the myeloid response? Apart from stimulating the cells to cause engulfment and endocytosis of the virus and destroy them, the myeloid response also causes stimulation of your cytokine system and leads to a cytokine dysregulation. So you have a phenomenal pro-inflammatory response in people who have COVID-19 because of the stimulation of the myeloid response. And this myeloid response typically happens in the elderly. That is why elderly people produce lower antibodies and produce more cytokines. And this COVID somehow pushes everybody to this kind of a, immunosenescent response, as we can say, where antibodies is not a predominant response. It is mainly the cytokine response resulting in the cytokine storm. This picture very nicely shows that in the initial stage of the illness, it is typically a viral phase, constitutional symptoms, dry cough, diarrhea, headache, lymphopenia, raised D-dimer, LDH. Subsequently, they go into the pulmonary stage, leading to shortness of breath and hypoxia, which can cause abnormal imaging studies and a low procalcitonin because there is no bacterial infection. And the third phase is a hyperinflammatory phase, which may go on due to a cytokine storm, leading to ARDS, shock and cardiac failure, typically high levels of interleukin-6, high CRP, high LDH, high D-dimer, and a high ferritin. So in the initial phase, you use remdesivir, and in the later phase, when there is an immune proliferation and a pro-inflammatory phase, you are looking at other immunomodulators like human immunoglobulin, interleukin-6 inhibitors, and JAK kinase inhibitors. So we have looked at the early phase. Now, what do you do in a person who develops what we feel could be a cytokine storm or an HLH? An HLH is also a manifestation of a cytokine storm. So steroids have been tried. In fact, we have been using Solumedrol 30 milligrams twice a day or 40 milligrams twice a day in our patients, even for the last couple of months with reasonably good response. We had used this in flu, but flu subsequently, the steroids were discouraged. It led to an increased possibility of secondary bacterial infections, which also we have been seeing in patients who end up on the ventilator. The risk of ventilator-associated pneumonia is much higher in patients who have been on corticosteroids. So we need to use corticosteroids with caution. Till recently, a paper came up from England, the recovery study, which looked at the role of dexamethasone. They had used a dexamethasone of 6 milligrams. We used, as I told you, 0.5 to 1 milligram per kilogram. The equivalent would be about 3 or 4 times the dexamethasone dose is what we have used so far. So after the recovery study, we have brought it down to using DEXA. We use DEXA 8 milligrams, which is equivalent to the 6.4 milligrams of salt used by the UK study. So our patients now, those who are worsening on oxygen therapy and looks like they are going down, we use dexamethasone 8 milligrams IV or oral once a day, and this may be used for up to 10 days. We are finding that this, if used at the correct situation, helps improve the prognosis. This is the recovery study where dexamethasone, as I said, 6 milligrams per day was used up to 10 days, and it reduced the deaths by 1/3 in patients receiving mechanical ventilation and by 1/5 in patients requiring oxygen without invasive ventilation. So it was also shown that the dexamethasone reduced the 28-day mortality among those receiving mechanical ventilation or oxygen, but not helpful among patients not requiring oxygen. So this is one of the landmark studies which have shown that steroids definitely, if used correctly in patients who are requiring oxygen and deteriorating, there is a role for steroids. Another agent which we have used with reasonable success is the interleukin-6 inhibitor, also available as tocilizumab or Actemra. Now, this, as I told you, happens because there is a pro-inflammatory response after about 5 to 7 days of the infection, leading to a high interleukin-6 level and high fever, worsening oxygenation, which probably may respond to tocilizumab. The tocilizumab, there is a study which came out 2 days ago. Unfortunately, I don't think I've added that in the Lancet, which said that using tocilizumab in a situation has improved mortality. So this is another agent after DEXA, which is showing use, but we need to be clear about when to use it. Abnormal chest images consistent with COVID, rapidly worsening gas exchange over 24 to 48 hours requiring more than 4 to 6 liters per minute with a respiratory rate of more than 30, absence of bacterial or fungal co-infection. If the person has already been put on a ventilator but has been there only for less than 48 hours, a SOFA score of more than 5, a rapid clinical decline, and most importantly, a high suspicion of a cytokine release syndrome, CRS, supported by interleukin-6 more than 3 times the upper limit of normal, high ferritin, high CRP, and an elevated D-dimer. So these are the markers which you need to do in a person who's showing rapid deterioration with the idea to decide whether he will benefit from tocilizumab. But please remember, tocilizumab is a biological which can worsen your immune response, so should not be used for in patients with active tuberculosis, hepatitis B or C, if sepsis is suspected, if there is significant transaminitis, significant neutropenia, thrombocytopenia, or patients who are significantly immunosuppressed. But these are all relative contraindications, and you may still use it if you feel that the benefit will outweigh the risk. The dose typically for an adult is about 4 to 8 milligrams per kilogram. We prefer to use a higher dose, 8 milligrams per kilogram, usually about 600 milligrams one dose only, maximum of 800 milligrams per dose. No data available on the benefit of a second dose. Second dose should not be a routine practice. The response will take 48 to 72 hours after administration. Please remember, once the interleukin has been documented to be high and you have used the tocilizumab, do not repeat interleukin levels because the IL-6 levels can actually go up after the usage because it blocks the receptors only. In the absence of fevers, worsening oxygenation alone is not an indication for redosing tocilizumab, and please exclude other bacterial infection. The adverse events may include GI disturbance, perforation, anemia, hepatitis, infusion-related reactions, neutropenia, and again, infection risk. What about other immunomodulators? We have used several agents, not us in Chennai, but people have used IVIG, anakinra, anti-GM-CSF antibody, anti-TNF alpha inhibitors, Janus kinase inhibitors, HMG-CoA reductase, statins, and convalescent plasma. But so far, there is no definite evidence to say that any of these are helpful. In fact, based on artificial intelligence, the JAK kinase inhibitors, especially baricitinib, which is an oral preparation given alternate days, shows very good promise based on modeling studies done using artificial intelligence. In fact, Chennai Apollo is going to start a study very soon, thanks to Dr. Balasubramanian, on the role of baricitinib in patients. So maybe after a few months, I may give you some update on that. Even though agents like nitazoxanide, ivermectin, teicoplanin all show in vitro activity, at present, there is no role whatsoever in using any of these agents. What about convalescent plasma? Convalescent plasma has been in use for over 100 years, right from the Spanish flu days. But the number of studies available are very, very small and few. There are studies with 5 and 10 people, and it should be used earlier in the phase rather than patient becomes very unwell. There are studies going on in India, but personally, I'm not very encouraged by that, but we have to see. I hope I may be wrong. The optimal dose, the time point, as well as the clinical benefit needs further investigation. So you can do it as part of a study, not as part of routine patient care. What about antibiotics? This is something I don't think anybody needs to tell us. We are very happy using antibiotics left, right, and center and giving it to all attenders also. This is something which, at least in my hospital, we have come down very, very strongly on. And thankfully, we have been very well supported by the physicians and the intensivists in our hospital. We use it only for a pneumonia complicating COVID, which is very unlikely, even when we compare it with the flu. We tend to monitor the PCT in the adults to see if there is a rising PCT associated with worsening oxygenation and increasing infiltrates, where we use antibiotics. Otherwise, none of our patients get antibiotics once they are confirmed to have COVID. Use of narrow spectrum agents like ceftriaxone or amoxiclavulinic acid can be done at the beginning, in the initial phase after drawing blood culture, when we are not sure it is COVID. But after that, unless the person goes into ventilator and develops a ventilator-associated pneumonia, we do not use antibiotics. And I'm proud to say that prophylactic antibiotics is not something which we use or recommend. Another important intervention is, it has been very clearly shown that there is a coagulopathy or an increased thrombogenesis, a thrombopathy or thrombotic tendency, especially in the small blood vessels of the lung, which contribute to worsening oxygenation associated with ARDS. So we use prophylactic low molecular weight heparin, enoxaparin or Clexane is what we used, 40 milligrams to 60 milligrams subcutaneously once a day for all adults. Please remember, rule out active bleeding, and the platelet count should be over 25,000. Therapeutic anticoagulation, where we use twice the dose, is typically when they have DVT or PE marked by a high D dimer, especially 6 times the upper limit of normal. Prolonged APTT is not a contraindication to anticoagulation, but monitor the factors closely. Lastly, what about Ayurveda? We are getting a lot of claims from alternate medicine. This cartoon was something which is very nice. When all the pharma companies are trying to fish, and suddenly somebody like Baba Ramdev comes and using a harpoon nets out 3 or 4 feet that fish that is a little difficult to digest. As of now, I think the claims are just claims. We don't have proof, but if they prove it, I'll be very happy, because at least we can push the indigenous market in India. Lastly, this is the algorithm which we use in Apollo. This is almost upgraded or revised on every other day almost. And my colleague, Dr. Ram Gopalakrishnan, is the one who's doing all the work in updating, going by the latest evidence available on what should be used. We have categorized it very similar to what we did for the flu. The suspect cases, what are the symptoms we need to keep in mind. And category A is mild, no admission, only outpatient management. Category B1 is when somebody is over 60 or has comorbidities, doesn't require inpatient management. Category B2, when what is outside referred to as moderate symptoms. And category C, which we call as SARI, severe acute respiratory infection. What are the tests to be done? What are the choice of start prophylactic low molecular weight heparin, remdesivir, steroids? And then you can look at these 3 are the only recommended ones. Low dose steroids, remdesivir, tocilizumab. Consider antibiotics in sick patients, convalescent plasma, and other experimental therapies based only in the context of a study. So to end with, I repeat, the Apollo protocol is purely supportive treatment only. Oxygen, low molecular weight heparin for all people admitted requiring oxygen, role of steroids if they are worsening, remdesivir within the first 10 days we tend to use in patients who have rapid worsening of oxygenation, tocilizumab where we suspect a cytokine release syndrome. Cytosorb is something which has been recommended again by FDA as part of an experimental therapy. We don't have proof yet, but it is something we can consider because it has been approved as part of experimental therapy. And same way, convalescent plasma, depending on further study results which are available. I'm going to stop with that. Yes, and I'm happy to take questions.
Thank you. Am I audible?
Yes.
Yes, Jagdish, you're audible.
Thank you, Dr. Ramasubramanian, for an absolutely fantastic outline of the absolutely accepted treatments and not the ones which are commonly used in many places. Some of the questions that I had was, One was the use of
Sir, it is
statin.
echoing, sir. Someone has two devices. Sir.
Just a moment. Is
Anybody kept mobile open, then it will echo.
no, I don't think so. No, there's nothing. There's nothing on here. Go over. I come in later. Dr. Balasubramaniam, can you go over, please?
Bala sir, you have to unmute yourself. Bala sir, unmute yourself.
No, somebody has. I have not. Yeah. Audible?
Yes.
Yes, sir.
Yeah. Jagdish, you please post your question here. I pass it also. Just put it in the box here. I can pass it on. Okay. Before I have a few questions from side. One, is a CT scan for all symptomatic COVID-19 adults.
The first thing is CT is used as a surrogate marker in the diagnosis of COVID, which may not be entirely correct. The pickup rate or the sensitivity of diagnosing COVID, even with the gold standard, which is the RT-PCR nasopharyngeal swab, is only about 70%. And even in asymptomatic people, if you do the CT, you may be able to find changes on CT. But if you compare the benefits and the risk, I personally feel that CT is not something which I would recommend in the diagnosis of COVID. If you are suspecting COVID, the person you suspected, you can repeat the PCR if necessary. But unless you have a specific reason, I wouldn't do CT as a screening test in the diagnosis of COVID. And even in asymptomatic people, you may have features of, ground glassing on CT scan. So yes, CT has a role, but not as a screening test to diagnose COVID.
Second question. Since remdesivir has been beneficial in those with hypoxia, would you consider starting this group even if the patient is mildly symptomatic without hypoxia?
This should be reserved. Remdesivir should be reserved for hospitalized patients. When I say hospitalized, I mean that there should be an indication for hospitalization, not because somebody is positive. He's showing hypoxia with a room air oxygenation of less than 94%, which means he requires oxygen and his oxygen requirements are worsening. That is, he's on 2 liters and it looks like he will require 3 liters or 4 liters to maintain the same oxygen saturation. Those patients may benefit from remdesivir. Please remember, just because we are using remdesivir doesn't mean that it is the best agent to use. It is amongst all the agents tried, it is the only one which has shown some trend towards improving the cases in whom they were used. So please remember, use it appropriately, because too indiscriminate use also is not good. So use it only on patients who are admitted, requiring oxygen, and are showing signs that their oxygen requirement is worsening. Yes. And within the first 10 days, definitely yes.
If asymptomatic features, does it require?
Asymptomatic people don't require treatment. Treatment is only for people who are admitted showing worsening. Otherwise, no treatment, only paracetamol they require for their fever and body pains.
Indications for X-ray. Suspected case.
Right. One, the X-ray changes take a longer time to manifest. So in a person who has fever in whom you suspect COVID, there is no point in doing an X-ray on day 1 or day 2. Generally, the X-ray takes at least 4 to 5 days to manifest. So see, any investigation has a downslide. X-ray gives radiation, CT gives radiation. So I would think hard before I get random X-rays done, because an oxygen saturation will give you more information than an X-ray. In admitted patients, yes, X-ray is necessary, and sometimes CT also necessary in patients with comorbidity for prognostication, but not as a routine.
Question we have had into with COVID PCR positivity, clinically behaving no respiratory symptoms. We are not doing any treatment, but we are worried due to high D-dimers, etc. What to do?
We don't treat the test results, we treat the patient. So if you have markers which probably may tell that there could be something wrong, we need to keep a closer watch on the person and probably repeat the markers after 48 to 72 hours. I have had patients who have been clinically perfectly normal, apart from lack of, this is in the initial stages when we used to admit patients. I still remember an elderly gentleman about 72 years old who refused to eat. He was one of the staff members' father, so he got admitted and would not eat at all. And he was just lethargic, fatigued, would not eat, no fever, no hypoxia, and his interleukin-6 levels were 2,200. So all we did was gave him IV fluids, gave him symptomatic treatment, and he recovered. I didn't have to use steroids. I didn't have to use, interleukin-6. So don't respond just to the report. Compare it with the clinical picture. If necessary, closely monitor, repeat the tests rather than throwing in everything you've got.
A very interesting question. After the initial phase indicates COVID. Dengue coming with the febrile fix.
Sir, I'm sorry, I'm not able to. Your audio is coming and going.
Jagdish, you try. Probably you. No, mine is also echoing.
Ravi, you try. You read.
Sir, Dr. Jagdish, sir, you have to unmute.
Bala, can you just mute yourself?
Yeah.
Yeah, now it's start. Now it's clear.
That's better. Yes, tell me.
Yeah, I think one of the questions was regarding use of statins. There is some study that shows that statins have reduced the mortality.
I don't think we should use medicines based on one anecdotal study which has 10 patients or 20 patients. Let us please remember that whatever we are going to do to help our patients should be based on sound medical evidence and not just one study or a few people or somebody's claims that it helps. I am sorry, I don't think that should be the case, because as such we are facing a lot of uncertainty, and I don't think we should do more harm based on some anecdotal evidence with the only idea of trying to do something to help the patient. So I don't agree with that.
Dr. Ramsubramanian, what is your experience with patients who suddenly die? There is some reports they suddenly die at night.
Yes, we have had our own share of patients who apparently seem to be steady. We had one patient who had been shifted to the step-down unit and then was suddenly found dead one morning. Very, very traumatic. We believe that the problems could be either due to a pulmonary embolism or it could be a myocardial infarction. Basically, there is a thrombotic tendency, and in spite of prophylactic, anticoagulants, sometimes they still develop thrombotic complications. So we have a lot of things to learn. As I told you, some patients present with acute myocardial infarction, some patients present with myocarditis, some patients present with stroke. So we need to learn a lot. Probably thrombotic complications is what I would think is likely.
There was some hypothesis that it is because of anemia in these patients.
I don't think anemia will kill you like that. It's more likely a vascular event. And we saw that in the flu outbreak also. I've had patients, I still remember one patient who was in the hospital for 2.5 months, went through ECMO, tracheostomy, ventilated for about 1.5 months, and finally came through, went home. A couple of weeks later, he came back for a checkup and he collapsed. When he was entering the hospital, he collapsed and died. The flu and the COVID and the SARS-CoV probably cause a high level of inflammation, a pro-inflammatory response, which may cause a vasculopathy also in future. So these are all hypotheses. I don't know, but yes, we do see sudden deaths.
There is one
There is
interesting
one interesting question
on the
on the
on COVID and diabetes
COVID and diabetes
and how it is
and
more
how it
difficult to
is more
control sugar
difficult to
in these
control
patients.
sugar in these patients.
Sir, I
Sir,
just
I
have
just
one
have one
request.
request.
If anyone
If
has
anyone
opened
has opened
YouTube, any
YouTube, any
panelist, can you
panelist,
please
can you
close
please
the app?
close the app?
It's echoing
It's
very
echoing
badly.
very badly.
It is only
It is
coming
only
for us,
coming
not
for
for
us, not
Dr.
for Dr.
Ramasubramanian. When he is
Ramasubramanian.
speaking,
When
it
he
is
is
not
speaking, it is not
echoing.
echoing.
Whereas all of us,
Whereas
when we are
all of us,
speaking, it is
when
echoing.
it is
What is the
echoing.
reason?
What is the reason?
Is it
Is it
anybody has up
anybody has
YouTube also
YouTube also
parallelly?
parallelly?
Ma'am, I
App
think
is
there
open.
App is open.
Dr. Krishna?
Dr. Krishna?
yeah.
Yeah.
Ma'am,
Mm.
From
SBS
SBS
system there are two
system, there are two
logins.
logins.
Sir,
Uh,
one
Sir,
can you
one
close, sir?
can you close, sir?
Dr. SBS.
Dr. SBS.
Ravi sir,
Ravi sir,
I think
I
yours was
think
there are
yours
three
was there
logins.
three logins.
No, I have not
No,
done.
I have not done.
I think it is.
I've closed everything. Only the laptop is there.
Laptop is there.
No.
No,
It's
no.
laptop itself.
Laptop itself.
If there are three
If
windows,
there are
please
three
close
windows,
one
please
window,
close
please.
one window, please.
Still echoing.
Still echoing.
Now I think SBS sounds much better.
Yes, it is better.
Yes, it is better.
Dr. Ramsuranam,
Dr. Ramsuranam,
or Meetan, what is your choice and why?
Right. I think that's a very practical question. The question is is that correct? Which steroid would you use? We were using methylprednisolone, but after the UK study, recovery study, we are now using dexamethasone. But please remember that there is an interaction between dexamethasone and remdesivir. So if you're using remdesivir, you either have to use a higher dose of dexa or much safer, use solumetrol or methylprednisolone. So in most patients, we use dexa, but if you're going to start remdesivir, we shift over to solumetrol.
Do you recommend home for those who COVID-19?
Yes, we do, especially elderly people, because now the Tamil Nadu government has pushed the home isolation very, very hard to save beds in the hospital. So all patients who are stable, we ask them to be at home. If they are elderly people, we advise them to buy a oximeter and use it. This is only for symptomatic people. What people tend to do is everybody is buying an oxygen saturation oximeter and checking their oxygen saturation daily 3 times a day. Healthy people don't require it. It's only sick patients who are home isolated. They need not even be sick. If they are home isolated, elderly patients, we always recommend, if they can afford, to use pulse oximeter and monitor their saturations 2 to 3 times a day.
What is a cutoff that you go to hospital?
94%. So if it drops to 94 or less, we suggest getting in touch with the hospital.
Somebody asymptomatic has high risk condition. Is there any for early steroid?
No. Please remember, the high risk conditions can be worsened by steroid. So please don't use steroids indiscriminately. Any intervention should only be after hospitalization, and that too, they should be specifically indicated. So if a person has worsening oxygenation, then start him on anticoagulants prophylactically, start him on steroids with or without remdesivir. Please don't use just anybody getting COVID. You don't need to admit him in a hospital and give him all these. Please don't. You have to hold yourself back.
Okay. Now, are you seeing lot of adults, or you are seeing more ARDS in adults?
Sorry, sir. Repeat. Are you seeing what, or are ARDS?
Are you seeing more fulminant ARDS or those with features of ARDS? Which one do you see more?
I'm sorry, sir. Just the crucial bits I'm missing. Do you see patients with...
I'll type it. I will type it.
This is in question answer or chat?
Chat.
In the both it is there. Sir.
Okay. I can see the questions.
Yes, sir.
Wait. Let me run through the questions then, because role of antibiotics with raised CRP according to guidelines for community-acquired pneumonia. No, because COVID-19 per se causes a high CRP. High CRP is actually a poor prognosticator in adults who present with COVID. So if this CRP is over 100 or 200, then that means poor prognosis. But I don't think you should choose antibiotics based on CRP. The next question is role of vitamin D. I don't think there is any role. These are all hypotheses, just like we have for tuberculosis and vitamin D. Right now, there is nothing to say that there is the importance of vitamin D. Yes, it is important as part of a nutritious diet and part of your immune response, but not specifically for COVID. COVID and flu vaccine, there is no connection between the two, but please remember that flu is round the corner, and the flu vaccine, whoever it is indicated for, it should be given for them, irrespective of whether COVID is around or not, because flu is preventable with a vaccine, COVID is not. If asymptomatic and CT shows features, does it need treatment? No. As I told you, it has been seen that there is some immune trick which this virus does, and even in patients who are asymptomatic, we find a lot of them having CT findings. This does not warrant treatment. When to take CT X-ray and CT chest in suspected COVID? As I told you, this is only in patients who are deteriorating for prognostication. If there is any route, suppose you suspect and 3 times the PCR has come negative, in which case this may be helpful. We have had dengue, ELISA positive children, 2 kids with COVID RT-PCR positive, clinically behaving exactly like dengue, no respiratory symptoms. We are not doing any specific COVID therapy, but we are worried due to expected high D-dimers APTT. This initially was presented in cases from Singapore about 3-4 months ago, when a lot of cases mimicked dengue. They were positive for dengue, but they were COVID positive. Please remember, the presence of one virus does not rule out COVID. Anybody who has a respiratory viral panel and shows positive for influenza or something else can very well have COVID also. And the presence of a viral etiology should not detract us from thinking of COVID. But treatment-wise, it is purely supportive. So, depending on what the findings and the clinical picture is, you may have to support both for dengue and for COVID. Can we start earlier than becoming tachypnic? I am not understanding what we can start earlier. I presume it's treatment. No, I don't think, because as I told you, 80% recover without issue. So there is no point in treating 80% of people, trying to see the 20% who may deteriorate. So let us not wait for them to deteriorate. Even then, as I told you, we don't have a specific treatment. Treatment is purely supportive. So I will not suggest treating everybody before they become tachypnic or before they require oxygen, with the idea that we may help save their lives. We don't have proof yet. Is the worsening after the initial febrile phase is over indicates COVID behaving just like dengue? COVID has behaved in a lot of different fashion. We have seen patients who deference after 4 or 5 days, stay all right for 2-3 days and then worsen. We have seen patients who have progressive worsening. We have seen patients who are fine for the first 5 to 7 days and then become worse. We still don't know. It is still too soon for us to come to any conclusions regarding how COVID behaves. Is in many centers, including government, give azithromycin to COVID patients by day 1. Is it right? No. This was done at a time where we were not sure of COVID, and we thought that any azithromycin is an antibiotic which will help treat conditions which the person may present with, either in the form of pneumonia or other infections. But right now, I don't think there is a role for routine azithromycin in our patients. Dexa or methylprednisolone, which is better? I think I told you we have evidence for Dexa. We don't have evidence for Solumedrol or methylprednisolone, but I think that both are reasonably acceptable to give, provided we give equivalent doses. In Bangalore, as you rightly said, community spread is rampant. Asymptomatic PCR positive presenting like other illness. How to diagnose? During times of pandemic, every person should be suspected to have COVID, irrespective of what he has, unless you have a categorically clear evidence. For example, somebody comes to you with fever, has right hypochondrial pain, has cholecystitis, then the fever is because of cholecystitis. Somebody has dysuria, presents with a significant colony count in the urine, and has urosepsis, yes. But otherwise, I think every person should be suspected to have COVID. What is advised medication for home quarantine and what parameters to be monitored? Home medication is only paracetamol and some vitamin. What parameters to be monitored? Temperature, and if, as I told you, the person is a little elderly or the person suffers from high-grade persistent fever, oxygen saturation 2 to 3 times a day. HCQS for prevention, what is your opinion? I haven't taken it from the beginning. I personally am not in favor of that, but ICMR recommends, so it can be offered. Zinc, vitamin C, and vitamin D in building immunity. This is, we have a lot of faith in our foodstuffs. We have a lot of faith in vitamins. In a person who is malnourished, in a person who has deficiency, yes, all these will make a difference, but not specifically against COVID. And right now, there is no specific evidence to load everybody with these vitamins. What is your experience with recurrences of COVID? So far, none. We have very clearly said that after day 8, the virus is not culturable, so it is not infectious. Even if the person has PCR positive, it is usually dead virus. We haven't seen any recurrences. It's only a repeat test being positive, not a recurrence. Can you summarize if a doctor or a family member becomes positive? I don't understand. What do we mean by can you please summarize if a doctor or family member, I presume that, now what should you do? There'll be 2-3 simple words of advice. If any one of you develop any symptoms and there is a remote possibility of COVID, the first thing you do is isolate yourself at home, because you are infectious for even 2 days before the onset of symptoms. So irrespective of what it is, you isolate yourself. If the symptoms persist for more than a couple of days, then you have yourself tested to see whether it is likely to be COVID. But isolation, protecting the other elderly people from in home where you don't wear a mask. Outside you wear a mask, but at home, since you don't, I think you should protect the other elderly home members. The other piece of advice is all of us have something called as self-positivity bias. We all think that we can't fall ill. We all feel that, COVID happens to others. Please remember, it can happen to you. It can happen to me. So if that happens, how are we going to face? You need to have a system in place. Whom are you going to call for help? Who is going to make the, cook at home? Who is going to ensure that medicines you need will be delivered to you at home when you are on home quarantine? All that has to be decided. You need to plan for an eventuality. If things don't go well, how you are going to be supported. Is it more of ARDS you see or cytokine storm without ARDS? This is all a question of semantics. Anybody who's deteriorating inevitably has fever, inevitably has features of ARDS. We don't even know ARDS is part of the cytokine response. So I think at this situation, when people are deteriorating, even with ARDS, there is evidence of a cytokine storm in the form of high IL-6, maybe high fevers, then there is a role for tocilizumab. What about quarantine after seeing COVID patients in private hospital setup? I don't understand this concept of quarantine. Quarantine is if you have been exposed to a patient. When I say exposed, that is without personal protective equipment. If you are examining a patient with COVID, proven or otherwise, but wearing a mask and washing your hands, that is not exposure. That is treatment. So patients, if you are seeing a patient without a mask and then that person happens to have COVID, that is an exposure. But I think in this time, all of us, irrespective of whom you are seeing, should always be masked. The patient should be masked, and you should wash your hands or wear gloves. So if that happens, I don't think there is any rationale for quarantining. Are there any early indicators that a particular patient can deteriorate? Yes, prognostic markers which include the NLR, the neutrophil lymphocyte ratio, which is the absolute neutrophil count divided by the absolute lymphocyte count calculated as a percentage. This is indicative of a poor prognosis if it is more than 3.13. Along with that, as I told you, a high CRP level, usually more than 100, high ferritin, high D-dimer are all markers that things may become complicated. Can flu vaccine trigger symptoms in asymptomatic patients? No. Have you ever used IVIG in COVID? No. How does D-dimer values guide treatment? As I told you, a high D-dimer indicates definitely that you need to anticoagulate prophylactically a patient. I wouldn't do a D-dimer unless I'm admitting a patient. Very high D-dimers can indicate in a poorly doing patient the possibility of a actual clot formation in the form of DVT or PE. Tell us about duty days versus quarantine days. Again, this question beats me because there is no need to quarantine. If you are taking precautions, you can work normally. There is no need to work in a quarantine in a COVID ward and then take 1 week off before you go back to seeing your regular patients. There is no need to have a 3-day break after every 2 days of work. There is nothing like that. It purely depends on your ability to work, your physical and your mental fitness. Apart from hypoxia, any other indication for shifting elderly with diabetes to hospital, like duration of fever? In general, if the fever is hectic and lasts more than a week or so, I will be a little careful in observing that person who is elderly, but otherwise no specific reason to admit. In COVID positive patients, if fever persists more than 7 days, requires admission? No. I've had several people fever running for 14, 16, 17, 18 days. I'm not admitted. I've monitored them. They've remained stable. Admission not needed. We are going through, I'm telling you, Bangalore is going to go through a phase. You'll be running out of beds. You cannot admit everybody who's just having fever. They need to have a reason to be in hospital. So please use your beds carefully. How long need you to take precautions to quarantine if COVID IgM positive? No, there is no recommendations. If you are IgM positive, it means at least you are 7 days into the illness, probably. And so 5 to 7 days more is what is recommended. Doxycycline, no role. If a person affected with COVID for the first time and he recovers, what are the chances that he may get affected again? As of now, even though the antibody response is poor and there is a possibility it may not be protective, the chance that he may fall prey to COVID again seems very unlikely. Influenza vaccine, which can be useful in preventing or reducing symptoms of COVID? No, influenza has no role for COVID. Which blood test to do, which day of the illness, so that we can prognosticate? In patients requiring hospitalization, CBC, PT-PTT, ferritin, CRP, PCT, D-dimer, I would advise. If the person is heading towards the ICU, interleukin-6 levels also is included. You repeat it every 2 to 3 days. Patients on remdesivir, daily SGOT-PT and daily creatinine has to be done. Please comment on Dr. S. Balasubramanian, sir. Please comment on pediatric presentation of COVID. This I'm going to leave it to him because he knows more. I'll see if I can finish another 4 or 5 questions and hand back the mic to Dr. SBS. What are the lab indicators which indicate probable worsening, which I've mentioned? Role of betadine gargle to decrease viral load? No role. Only constant mild throat pain with no other symptoms can we suspect COVID? No. Please summarize about home quarantine. I've told you home quarantine is for patients who have suspected or proven COVID. Single room, preferable attached bathroom. When you're coming anywhere within 6 feet of anybody else, wear a mask, both of you. No sharing of items, toiletries or soaps. No getting out of the house. No visitors coming into the house. Wash your hands frequently. And if somebody else is coming into the room, wear masks always. Does a desire and drive to live help recover from COVID? Absolutely. The more positive thoughts you have, the better your immune system is. When will we get a vaccine? Probably 12 to 18 months realistically. N95 or surgical masks in OP practice. I use only surgical masks, N95 only for aerosol inducing procedures. Make sure that the patient is at least 6 feet away from you. Do not examine the patient unless absolutely necessary, and make sure that both of you wear a mask. Comment on pediatric OPD presentation, again to SBS. Role of statins, theoretical, no role yet. When to discharge? Discharge is recommended if the person has been asymptomatic without fever for at least 3 days and at least 10 days after the onset of the illness. After this, 1 week of home quarantine. Drinking hot water, no use. Already in Karnataka, new recommendations mention admission for all COVID positive patients. Now that is how it started in Tamil Nadu also. In another 2 to 3 weeks, you'll realize that, you cannot do anything about it and you will resort to home isolation. So this is all a part of learning only. Role of azithromycin, no role. When to suspect COVID in child with GE? Every child, because in children, COVID is very mild. You need to think of every child who presents to you as a possible COVID, especially if there is a household member who's not well. Otherwise, it's unlikely that they will get COVID. Do you have counselors to uplift their morale for the mild to moderate cases? Mrityunjaya mantra and Dhanvantri mantra. Yeah, very interesting. If you believe in that, yes, absolutely. Is Tamil Nadu seeing a low mortality rate? If so, what could be the cause? We are doing a lot of testing. So when your denominator increases, the mortality will also come down. When do you predict herd immunity? Another 3 to 5 years. It is believed that every outbreak you have causes immunity in about 30% of the population. So you need to have at least 4 to 5 outbreaks to get to 60%. That will take 3 to 5 years. When are we expecting a vaccine? Infectivity rate of a person with prolonged positivity. You generally don't stay infectious beyond 8 to 10 days. So even though the PCR is positive, the culture has always been negative after 8 days. If healthcare worker was asymptomatic, wears N95, is it risk to the patient? No. I told you the mask, even regular mask will bring it down by 70%. COVID negative but IgM positive presenting with inflammatory syndrome, should we follow precautions? It is unlikely to be infectious, but yes, I would still follow precautions. Role of aspirin, no role. Should we skip throat examination? Yes. You should do throat examination because you don't know whether you're missing an acute tonsillitis or something like that. But make sure you wear an N95 because a violent cough can cause aerosolization. So when you're going to specifically look into a patient's throat, I would prefer an N95 over a simple surgical mask. Are you repeating a PCR before discharge? No. Thank you, Dr. Ram Subramanian. Wonderful talk. Thank you very much. I'm going to put you back on to SBS to take care of the pediatric stuff.
I hope now it's not echoing.
Still echoing.
I can't help.
You can tell us about the pediatric COVID, sir.
Yeah, that of course.
That is echoing a lot.
Great stuff. 20. The questions so fast, and more important, your session of science based nicely out of medical practice. That's what I like. And the message in the form of medication and rational medications that are available, steroids, tocilizumab, etc., was really very, very useful. Since you give some idea about COVID, I would add one is that the number of cases in children has not been very high. The percentage has been only around 6 to 8% in most parts of India. If somebody asks me if I have personal experience with COVID-19, I would say yes, I have personal video experience because I don't see them directly because I'm a senior citizen. I see them through video. But from our hospital, I can summarize our experience. We have tested for COVID in about 230 odd children so far. And our positivity rate has been around 10%. 23 is our score today. And all of them have done exceedingly well. None of them had required antiviral therapy. None of them were ventilated. We have had around 9 cases of pediatric multisystemic hyperinflammatory syndromes, out of which 6 have been proven to be COVID PCR positive, 3 negative. We are hoping to get antibody tests for the remaining. Most of the children have been mildly symptomatic with any other acute febrile illness or flu-like symptoms. A few cancer children have had febrile neutropenia and they have done exceptionally well. We admitted them because of febrile neutropenia and the investigation for COVID PCR being positive. They have all done well. So far, it has been a very smooth ride for pediatricians. Hopefully, this will continue, but it is expected, it is predicted that in pediatrics, it is not going to be COVID-19 per se, which is going to be a problem. It is going to be the pediatric multisystem inflammatory syndrome. But if we have seen nearly around 10 cases in our hospital in the last 2 months, I am sure in Karnataka, you are also going to see this. Awareness should be there. Most important message I would say to pediatricians, if a child has fever and abdominal pain, today we have to think of the hyperinflammatory syndrome, and we should be careful. Even if there is an ultrasound report of appendicitis before opening up, this may well be the pediatric multisystem inflammatory syndrome temporarily related to COVID. With this, I would hand over to Jagdish for his further remarks. Yes, Jagdish?
Yes, sir. Echo has stopped, I think, now.
Yeah. It's fine. Wonderful.
So I think it's I think it probably was a scheme where Dr. Ramasubramanian was going to ask the question and answer it himself. So I think there was some plot there. Anyway, so thank you, Dr. Ramasubramanian, for a fantastic expose on the COVID-19 thing. And as you rightly mentioned, Bangalore is already full. All the hospitals are full, the ICUs are full, and people keep calling even now for admission to various places. And as you said, the major problem is admitting all patients who don't need to be in hospital. And unfortunately, sorry to say, but there are a large number of influential people who are getting into the hospital ICUs and beds and knocking out everybody who really needs admission. So that seems to be the basic problem right now. You have very clearly mentioned that the only treatment required is careful watching with paracetamol and nothing more, and isolation. And I think that's what needs to be brought into this thing. The other plea I sincerely hope that we can make, since Dr. Ravi Shankar is here, is to convince our authorities to enforce masking, because our people, whatever amount of education you give them, unless it is enforced and with fines, they are not going to mask, and this disease is going to spread even more. So I thank you again for a lovely talk, and also asking and answering the questions yourself. And thank you, Dr. Balasubramanian, for the brief outline of pediatric COVID. I'll now hand it over to Ravi Shankar to propose the vote of thanks.
Yeah, thank you, Dr. Ramasubramanian. The one sentence which I loved it, and probably I will continue to tell for another 1 week, is I am talking, the phrase, I am talking with heavy dose of common sense. Somehow I love this phrase, and probably that is what we require now. The heavy dose of common sense, that is what we require. Every day the WhatsApp Institute gives plenty of information to us, which we always get frightened, relaxed, something like that. But what we are missing is the common sense. So every case of COVID and every neighbor who has got a COVID, probably what we require is a common sense, not to get frightened, not to insult those guys. That's probably that we have to keep it in mind. Of course, the pediatric COVID, as already Dr. Bala, SBS told, we are seeing less. Even in fact, our hospital is also started admitting the cases, but not even a single case of pediatric COVID has come. Most of them are occupied by the adult COVID. So that's the reason probably I don't have any much questions to ask, although I thought of asking few questions, like maybe SBS may answer this. Earliest we can start on steroids, if possible, and interleukin-6 level in children. And if you are using remdesivir and favipiravir, what is the dosage and when we can start that one? Any idea, Dr. SBS? Anything about these 4 questions? First thing is when we start on steroids.
I will tell you
the pediatric point I'm asking.
Yeah, first I will tell you what I do not know. I do not know the correct use of remdesivir in pediatrics, to be very honest. But if I'm going to think of it, I'll definitely call Ramasubramanian and start the drug. It's a very honest answer, number one. And I have fortunately 23 cases we have seen, and none of the cases we thought of starting any remdesivir. That is the second part. Third is the pediatric COVID is definitely different from adult COVID. I think one message pediatricians should all take home from this session is that unlike adult COVID, which has respiratory manifestations primarily, pediatric COVID, if they are going to come to hospital, their respiratory manifestations may not be significant unlike the adults. And they are going to have abdominal manifestation, they are going to have vascular manifestation, they are going to have KD-like presentation, dengue shock-like presentation. That's what we should remember. And coming to the use of steroids in pediatric COVID, I'm afraid I don't have straightforward answers. Guidelines are still evolving. But in pediatric multisystem inflammatory syndrome, currently the first line of therapy is IVIG plus or minus steroids. And there is a tilt towards giving steroids. Anakinra is not available in India, so we have no choice. We have an alternative in the form of tocilizumab, and it is still an evolving ball game. But I can tell you, with the cases that we have had so far, about 30% have responded very well to IVIG. About another 30% have required methylprednisolone. 2 cases have recurred without any treatment. That is regarding the multisystem inflammatory syndrome. But I am afraid with this, I can't give any recommendation. There is no uniform protocol. We will hear about it. Right now, trials are going comparing IVIG with steroids and steroids alone in a 2-arm trial. We will know which is good. But in a low-cost scenario, like in a government institution or in a patient who cannot afford, in a hyperinflammatory syndrome setup, giving steroids alone may not be completely wrong. But on the other hand, if you have features suggestive of Kawasaki, you better treat with IVIG with or without steroids, with or without aspirin in the Kawasaki protocol when you are in doubt. That is my answer. But I would also admit, at present, we seem to have more that we do not know than what we know. Answers might come in the future, very soon, hopefully fast.
One last question, Dr. SBS. If the parents have got, somebody in the has got positive COVID and children are there, any role of prophylaxis? Because the parents will be asking.
Absolutely
so,
no.
Sir, my child requires any prophylaxis less than 10 years, above 10 years?
I belong to the school of Ram Subramanian. Absolutely no, there is no room for any prophylactic medication. All you do is counseling. All you do is proper counseling. Counseling on warning signs, counseling when they should reach the helpline, when they should go to the hospital, counseling on mask, counseling on protection. In fact, I am fond of saying 3 things: Brahma, Vishnu, and Shiva. Brahma is usually a god who is not visible. So mask is very important. Remember Brahma. Okay. Shiva is the destroyer. Hand hygiene. Hand hygiene. And Vaishnava, Balaji. Balaji is somebody who's very difficult to see. So you can see him only from a distance. Social distancing. I think Brahma, Vishnu, Shiva, this is what we should remember. This is what we should tell the parent. Then talk about prophylactic medications.
Nice.
One small advice you should give them is not to go and hug grandparents.
Yeah, correct. That is true. Yes, right. That is right. That is a common mistake all the children will do. When the parents come inside, immediately they'll hug. That probably we have to avoid that one. Yes, it's a nice one. And actually, Dr. Ram Subramaniam, this is basically a Fever Foundation, entirely a academic activity by Dr. Jagdish. He requested to associate it. That is his. I'm really thankful to him for that one. In fact, it has been seen by all over India. Many my Bombay Dr. Jagdish friends also seeing Dr. Upendra Kinjalwadikar. It is broadcast over India, not only just restricted to IIP Bank. It is seen by from all over India. Yeah, that's what I want to highlight that one. Yeah, Sumita, you can take over.
Thank you very much. We have had a really enlightening afternoon with a lot of deliberations. So first of all, thank you to Fever Foundation for organizing this. Dr. Manjula, thank you very much. And of course, our excellent faculty for this afternoon, Dr. Ram Subramaniam, thank you for clearing all the doubts that have been lingering in the minds of many of us, our colleagues. The basic thought is, what do we do if any of our colleagues or any of our family members or neighbors or even ourselves require help? So thank you once again. Thank you so much for clarifying all the doubts. And a big thank you to Dr. Bala sir and Dr. Jagdish Chinnappa sir for moderating this session and for asking the right questions, if I may say. So thank you so much. for giving us this session today. And Fever Foundation Microlabs, once again, heartfelt thank you to you. And thank you, Dr. Ravi Shankar, for having accepted Dr. Jagdish sir's offer for us to be associated. And of course, no webinar is complete without the audience. So the audience has been really, really good, asking a lot of questions, getting a lot of answers from Dr. Ramasubramanian. So thank you all once again. Thank you very much for this excellent webinar this afternoon. Thank you.
Whenever Jagdish asks, immediately I will accept, because I know that webinar will be the best one and a lot of interesting academic thing will be there.
I support it. I agree with you.
Thank
So
you.
before
Thank you very much,
close,
sir.
Mr. Jairaj is there. He would like to speak towards it from Microlife Executive VP.
A formal vote of thanks is also over. In any case, it's my duty to thank on behalf of Microlabs and Fever Foundation for an excellent webinar. First, thanks to IAP Bangalore chapter and dynamic personality and Dr. Jagdish Shinnappa for bringing in such luminaries for this event. Also, would like to express my gratitude to the eminent speaker, Dr. Ramasubramanian. Has been fantastic throughout. And words are not enough to express my gratitude to Dr. Balasubramanian sir to chair this session and coordinate everything. And also would like to thank Dr. Manjula and her medical team, our sales and marketing IT team who did all the coordination, the fantastic audience for being with us and keeping the interaction vibrant and live. Thanks, thank you, and thanks to all.
IAP Bangalore, all the president and the secretary.
Thank
you.
Dr.
Thank you,
Shankar,
Thank you
for
all,
being
sir.
with
Thank
us.
you so much.
And
And
Dr.
it was really
Thank
wonderful.
you.
Thank you very much.
Thank you.
Bye-bye. Thank you. Thank you, ma'am.
Thank you.
Thank you.
Thank you, ma'am. Thank you,
Sumita,
sir.
ma'am. Thank you.
all.
Thank you. Thank you, sir. Thank you. Thank you, Dr. Manjula.
My pleasure, ma'am. Thank you.